My name is Nicole. I'm from North Hills Hospital. I am the clinical educator for emergency services. I had the pleasure of being part of the TCU fellowship this year. And my presentation and project this year was over ER admission report, handover report from the ER to the inpatient units. It was also part of my hospital's AHRQ action plan regarding patient safety. So the problem we had that I discovered was our old process. We sent the computer-generated SBAR to the floor. The process that happened was the doctor wrote the order, the patient got put on the bedboard, and then once we got a room assignment, we sent the computer-generated SBAR. The floor had 15 minutes, and then after 15 minutes, the ER would transport the patient up. In those 15 minutes, the floor can call down with any questions or concerns, but if the ER didn't hear from them, they assumed all was good and they transported the patient up. This process was in place for PCU, CSU, and MedSurg. For ICU and CCU, they still did call report to those nurses and spoke to them on the phone. The floor nurses had many concerns with this process. They felt like 15 minutes was just not enough time to review the SBAR. A lot of times they were in the middle of getting medication or seeing their current patients on the floor. They also said the SBAR didn't always get received, and the main thing was that the SBAR was very dependent on the nurses charting. So if they were behind in their charting or maybe weren't as diligent in their charting, the SBAR might have not had all the important information that they needed. The floor also felt that because they never talked to the ER, that they were just getting the patient settled and then leaving, not ever thinking twice. I many times heard the ER when they were talking about ICU or CCU report saying, why can't they just read the chart? It's all in there. And yes, it probably all is, but that takes a lot of time to dig through and it's very easy to miss information if you're just reading. They would also say this if the floor nurse called down for questions, which sometimes I felt like made the floor nurse discourage them from calling, which wasn't okay. And lastly, if you have a train wreck of a patient, or by other words, if they're a very complex patient, have a lot of comorbidities, maybe you're on a lot of different drips, different medications, maybe they're septic with an MI, there's a lot of things that can happen. It's hard to get a full clinical picture on those patients with just reading an SBAR. If it's something simple, maybe, but if they're more complex, it's a lot more difficult. So this led me to the question, for inpatient nurses receiving admissions from the emergency department, does adding a verbal handoff tool with the SBAR written report compared to only the SBAR written report increase the floor nurse's knowledge and readiness to receive the patient? I did a literature review. There is tons of research out there on handoff report. It was actually more challenging narrowing it down in my case, but I did narrow it down to 4 systematic reviews, 5 individual studies, and I came to the conclusion that written report was more consistent, but verbal report was less likely to omit important information. My methods, I did a pre-change and post-change survey on the PCU unit. I asked the nurses to rate the current process they were using on a scale of 1 to 10, 10 being the highest. And then also to measure patient safety, I asked the nurses if they felt ready enough to safely receive their patient with the current process they were using. In the pre-change survey, I also asked the nurses if they received a phone call along with the SBAR, and the phone call was a short 2-minute synopsis of the patient, what would you need to know in that phone call? We performed a 4-week pilot on the PCU unit. I created a verbal handoff tool that I created by using the question in the survey. I summarized what the nurses wanted and compared it to what was already on the SBAR. The new process that was implemented was that the SBAR would be sent as soon as the patient went on the bedboard. So if they were going to MedSurg, they would just send that to every MedSurg floor that we had, and our hospital has 2. And then if they're going to PCU, CSU, and so forth. Once we got a bed assignment, the ER would call report immediately to the floor. If the primary nurse wasn't available, they would ask for the charge nurse or another nurse. If no one was available, they would wait 5 minutes, call back, and do the same thing. In order to help with throughput and to get the patients up in a timely manner, there was a 2 phone call limit. If not a single nurse was available after 2 phone calls, short of something big on the floor like a code blue or an RRT, they would go ahead and push the patient up. and confirm, but before they do that, they would confirm that the written SBAR was received, and then the floor nurse would call down later to get a report. This is a picture of the verbal handoff tool that I created. Some of the stuff is on the SBAR, some of it is not. Diagnosis, for example, is, but it's important to discuss that anyway. The assessment, it's very hard to get a clinical assessment off the SBAR. So they would talk about whatever wasn't within the normal limits for that. And then, for example, labs is on the SBAR, but critical labs is just something we felt it was important to talk about. The pre-survey data, before we did the change, the average was 3.4, and after it was 8.1. And when asked if they felt ready to receive the patient, it was a big outstanding no before the change. And I believe I got all yeses and maybe one no after the change. And this is a pretty graph that shows the 3.4 compared to the 8.1. So my conclusion is that written and verbal report give the most informative, consistent patient information. I recommend that the written report be sent to the floor as soon as possible, and that once the bed's assigned, that the emergency department nurse send call report to the floor to give a full clinical assessment picture of the patient. The lessons learned. I was also asked by our senior leadership team, kind of outside of the study, to track if this is going to affect our throughput numbers. We all know we like to get the patients up within 60 minutes. The patients are happier when they get up faster. So I tracked that information, and it did not show that there was a significant delay with this process. And I believe that's due to the two phone call limit, but any delays that there were during the 4-week period were all justified in other ways on the 24-hour report. The floor also asked in our debriefing at the staff meeting after the pilot, well, what if the patient goes to surgery? They're not calling report on those patients. And after deliberating with the directors, it was decided that it's best for surgery to call on those patients, because when ER sends them to surgery, they don't know where they're going. It was also asked, well, what if the patient goes to dialysis? And it was decided that yes, they would call report for dialysis. It's a little different than surgery. When patient goes to surgery, they never come back to the ER, but when they go to dialysis, if there isn't a bed assignment, which rarely happens, they would come back to ER. So if they got a bed assignment while in dialysis, then the ER does need to call report to the floor to give them a heads up of the patient. And then it was also asked about cath lab, which is very similar to surgery. It was decided that cath lab would be calling report to the floor. That's my bibliography. Any questions? Yes, ma'am. The first week, because I did manual chart audits of all of them, it seemed like we had more just the written report going up, at least with the pilots. But as the floor nurses saw that they were coming up regardless, whether the floor nurse, the primary nurse, or maybe the charge nurse worked out a system where they made it a priority to get the phone call. There were times where they did take the second phone call, but they did get report and get up in a timely manner.